This is the EMS Research Vlog and Podcast, where we talk about the research-related issues that matter to those who work or study in the area of emergency medical services. Your host is Bram Duffy, who is a paramedic and communications professor.
Gastric lavage is a method used to clean out the stomach after someone swallows a poison, and the goal is to reduce how much of the substance the body absorbs. Other decontamination methods, like using activated charcoal, are now used more often and also have further reduced the role of that need for stomach pumping, gastric lavage. So, reflecting that, the American Academy of Clinical Toxicology advises that gastric lavage should not really be performed routinely for poisoning patients. And so, because of that, I was surprised to find an article in Prehospital Emergency Care called Prehospital Gastric Lavage for the Treatment of Critically Ill Overdose or Poisonings, a case report. And that study talks through a case that dives deeper into this issue. I'm so happy that today we have one of the lead researchers here with us to talk about that article, Dr. Nicholas Studer. Can you please tell the audience about yourself and so that we can learn more about you before diving into the article?
Sure. This is a little bit less of a research, project than it was an interesting case that we were able to present in PC. My name is Nicholas Studer. I'm the System Medical Director for the Army Office of Surgeon General, so helping develop some of the clinical oversight for the Army EMS system, which is all the installations throughout the world that we have that are Army installations that have paramedics and EMTs. In addition to that, did my EMS fellowship with the UT San Antonio Health San Antonio based program that's with Brooke Army Medical Center, as well as with the City of Austin, Travis County, and then Cypress Creek EMS, which was actually where this case was in Harris County ESD 13.
And you came upon this patient. Can you tell us about this special case that you had, and so that we can talk more about gastric lavage in this case?
In this case, it was a 72-year-old female with unconscious, unresponsive. History included a number of different conditions, including hyperlipidemia, hypertension, and basically had been found in, almost stereotypical in a pile of pills, which included baclofen, which was key to this case. So EMS responded as soon as the 911 activation occurred and arrived within about 8 minutes. There was an advanced paramedic. That system was designed with advanced paramedics and also a physician field response using EMS fellows. I was the fellow at the time for that month. Fire department got on scene initially, snoring respirations, clenched jaw, foamy emesis, all the typical things that you'd see with toxic ingestion, even with opioids or similar to that nature. But there was no evidence of opioid intoxication. Pupils were actually fairly dilated, bradycardic, hypoxic, clenched jaw, trying to place an OPA had failed. There was increasingly poor saturations. And we got the fire department crew that initially responded was BLS. And as the paramedic arrived, got an IV established and got them to the ambulance. All of this, by the way, was on body camera. So that was part of how we were able to do some of the case writing as well as the quality assurance on this. But once they were moved to the ambulance, continued to have hypotension, bradycardia, was quite ill. Ended up with widening QRS, given sodium bicarbonate at that point to do a sodium load to try and overcome what we thought was perhaps some sodium channel blocking action of baclofen. And we were able to get our pressure well enough with 100 microgram boluses of epinephrine, which is a fairly substantial push dose of epinephrine, to get us to a rapid sequence intubation, and continued to deteriorate despite epinephrine infusion, good ventilation. And at that point, it decided, this is a potentially lethal ingestion. And if we look at the ACT guidelines, what it specifically says, it hasn't been updated since 1997. It's Based on experimental and clinical studies, gastric lavage should not be considered unless the patient has ingested a potentially life-threatening amount of a poison, and the procedure can be undertaken within 60 minutes of ingestion. And timelines are always difficult, and I'm very lucky. The Army doesn't have a lot of high acuity patients within the former Army, now Defense Health Agency combined military health system. In general, our patients are often very healthy. Some sites are less healthy than others, and some sites have more acuity. But in general, as you would expect, this is a healthier population that doesn't have a lot of the urban problems that you might see, in Harris County. So our training, because I was trained through the Brooke Army Medical Center Emergency Medicine Residency and the EMS Fellowship. It's also a combined disaster medicine fellowship. They sent me to the New York City Poison Center. So I got to train underneath Dr. Goldfrank and Dr. Hoffman. Dr. Hoffman is an advocate of gastric lavage. You'll find that a lot of toxicology is very based upon best evidence and very limited data, very animal study oriented, case study oriented, because it's not ethical to apply, randomized controlled trial to humans on poisonings and then to apply different treatments to them. So the best guess that I would say all toxicologists probably agree with this, if there is no known antidote, it's a very recent ingestion, and you believe that they will die unless, because there's no antidote and they're deteriorating, which in this case, I think that patient met that, and so did the reviewers for PEC, and obviously one of the luminaries of toxicology, who is one of the main editors of the textbook, Goldfrank's Toxicology. Those ethos arguments there alone, I didn't have those at the time, but I made the decision, I think this person's going to die unless we do something radical here. And like many heroic type procedures, that are increasingly common with EMS physicians in the field. Thoracotomy, central line placement is common in emergency departments, but not common pre-hospital. Had an Edlich tube and was like, you know what, let's give this a shot. And I actually got a fair amount of pills out. And as the AACT guidelines from 1997 would tell you, yes, you get dramatic returns, but and the case studies have these dramatic improvements, but just as a animal study response, we're not sure that this really changes things. But we went from hypotension that was refractory to very high dose, probably not perfectly calculated high dose epinephrine infusion, to not requiring any restoration at all in about 5 minutes.
So when trying to decide to do this procedure, I'm thinking, I have like these two balancing thoughts on my head. One is that, gosh, this patient has been affected enough by this toxin to be this unstable, which means that it's already that far, down the road in their system. So, so that's one thing. But the other thing that I'm thinking is that, it seems like the thought of activated charcoal fixing everything will only work if you can get it to the right source. So part of gastric lavage is being able to administer activated charcoal to a patient who's unresponsive. So
That's true.
those are my thoughts. So like
So activated charcoal is an adjunct to lavage, and if you're going to be doing lavage, you should do charcoal in general. It depends on the type of agent. If it's a charcoal binding agent that will bind charcoal, that would certainly be helpful, but some agents won't. The reason charcoal wasn't used in this case, it was one of the things actually the reviewers brought up, is we didn't have it. And that's one of the things you'll find in limitations that we had, was that charcoal is on shortage at times, and it didn't come in the particular kit that we had. To be honest, I didn't really worry about the fact I didn't have it, because I wasn't ever expecting to really do it. This is such an uncommon procedure. The reason it was so common in the 80s was tricyclic antidepressants. Paramedic school taught me to give them sodium bicarbonate. But that's not really a good antidote. It's just we don't see tricyclics, and they're not prescribed for quite the same reason. They're more for headaches these days than migraine prophylaxis, than they're being used as a treatment for depression. So of course you're going to see less, toxic ingestions of amitriptyline and similar agents like that. So I think, what you're getting at, and I would agree with, is Your unconscious patients, they're generally getting an OG tube, either in the emergency department or pre-hospital. I encourage it pre-hospital. Every time you get intubated, I place an OG tube. And we suck out what's in the stomach in the vague hope that, the aspiration, will be less likely especially if they vomit, because we all know that cuff isn't perfect and there's secretions and all these other things. So the sooner we drain the stomach, sure, that's what everyone does. It's not really lavage. The difference with lavage is that you're either putting bolus of charcoal in there, letting it sit for maybe 10 minutes, pulling it out, doing fluid boluses. In this case, we did 50 to 100 mil boluses. One of the problems that you see in the other countries where this is more common, especially in Africa, where paraquat is more common, and there is no good antidote for that. It's very resource limited, and they're even reusing at times the very large rubber hose that they use for the lavage procedure, in which case, they'll dump in 500, 1,000 mils, and there's no airway protection because they're also not intubated. There's more risk with that. But yes, you want to get charcoal in, and in this case, charcoal would have been a great option. The protocols for Department of the Army and Department of the Air Force are being updated this year, and we're putting charcoal back in. There was a little bit of a disagreement between various toxicologists that were advising the EMS physicians on the board that makes those protocols, and the Air Force toxicologist was a little bit less excited, and the Army toxicologist didn't really get a great opportunity to say they had a different opinion, and we revised that and now basically went back to what we had in 2022 with charcoal. So charcoal is absolutely excellent. Should it be done, you can put it in with just a standard 18 French Salem sump tube. You don't need the 34 French. The 34 French tubes are used to pull out pill fragments. And in this case, that's what we assumed there were. And boy, we got a lot of pill fragments out. That's for sure.
So you had talked about we're actually talking about the fact that there's a lot of different opinions about what we should be doing with gastric lavage. I know that the American Academy of Clinical Toxicology, has looked down on it, and that's why we don't do it as much now. But you had mentioned that there were some really specific recommendation areas, like we should really consider it in these certain cases. Can you review some of those with me so that I can be clear, like what
Sure.
those exceptions would
So the
be?
AACT guidance, so the AACT guidance looks at emergency departments. It doesn't look pre-hospital, and it is over 25 years old. So when it comes to pre-hospital, the conclusions that we had is that it's reasonable for EMS physician-based field response. It's not that it's technically complex. I think that an advanced paramedic, and I'm a very strong believer in advanced paramedic programs, that it could technically be done, but it's not even so much the decision making that makes it so difficult. A paramedic can identify certain agents, and you could even put it in a protocol that would be amenable perhaps to gastric lavage. A lot of it really is how not routine it is anymore, because these poisonings are so rare. I would be uncomfortable putting my paramedic in that position where they have to explain it to a certain, to a certain degree with a physician, even with online medical control support. It's so rare. Is this what we put our support into? Is this where we put our resources when, maybe I'm looking for a few more dollars for a cadaver lab, or I really want my folks to be able to do simple thoracostomy or escherotomy or something like that. We have escherotomy in our protocols, and certain agencies have that, and it seems to be about a once-a-year procedure for the agencies that do have it. So one paramedic out of the entire system is getting to do it. What you need to have, and this aligns with the guidelines that are very old, and what would be, I would say, a fair majority of toxicologists, which is difficult to get them all to agree, is that a potentially life-threatening ingestion with no known antidote or a poor antidote, recent timeline, and we have tried other things and it's not going so well. And we believe they're going to die, or else if we don't do this procedure. And so in this case, this is what I thought it was at the case. And yes, that was a rather aggressive decision, and it worked, as we believe, otherwise it would be published, right?
Yeah.
But I think that it was to be a very, very limited subset of cases. The same thing is, with perimortem C-section. Should paramedics do perimortem C-section or not? Clearly, paramedics have. There's stories that have come up into that. And you look at other countries, Korea just this year in January made it so that it was legal for a first-class emergency medical technician, their equivalent of an advanced EMT. There are no paramedics in Korea to deliver a vaginal delivery at all. That was just a recent change. So it all depends on where you are, what your toxicologists believe. The Northeast is more inclined towards using activated charcoal. Other places are less inclined to use activated charcoal. It really depends on what you're looking at. So that's why our conclusions, I'm very rarely very physician-centric for the pre-hospital environment. This was a great case, very cool case, otherwise it wouldn't be published in Prehospital Emergency Care. But
even with
very documented.
Even with the things that you mentioned, and this is just me shooting from the hip here, but what's wrong with us just planning for every patient who's bad enough for us to need to intubate to protect their airway? Why not just go ahead and do it? Because I'm thinking that, when we're doing a cost benefit analysis, it's always about making sure we can maintain airway, right? So if we have 100% airway and we know there's stuff in the belly, why not?
So that's kind of how folks perceive things up until the early 2000s. And what you'll see is that the cuff is not perfect. So first is mechanical trauma is with aspiration. That's what everyone thinks about. But there's also a risk of mechanical trauma. If you're using a tube large enough to remove pills, so not using an 18 French Salem sump, you're using an Edlich tube or Levacuator or any of the other, Tummy Vac is another brand. They're very large. So you can definitely, if they've got gastric varices, esophageal varices, there is a mechanical trauma risk, even if you have normal anatomy. And if you're not doing this a lot, this is a tube that's very similar to sometimes what's used for, endoscopy, scopes of the stomach and so forth. It's about that diameter. If you don't do this a lot, which I don't, it's harder to know what is okay and how hard to push to some extent. That's one of the risks, is mechanical trauma. The second is the aspiration risk that everyone thinks of first, and that cuff is not adequate on the endotracheal tube. So even though you can reduce your risk by giving lower volumes, which some of the described troubles with it in the 90s were related to dumping 500 mils or 1,000 mils at a time with nurses placing these. It generally wasn't the physician. And sometimes it was people that were awake. To some extent, this was almost punitive. You took a bunch of Tylenol, and I remember I was there for some of these sort of things. It was all very, very interesting. And even in the early 2000s, when I went to EMT and paramedic school, you'd see this stuff, and you're like, oh, well, that's what we do. They can aspirate and they can get around the tube, and that's the second major complication. When it comes to the improvements that could be there, it's hard to say. Even charcoal hasn't really truly demonstrated this mortality benefit that we're really looking for. So does an individual patient improve? Do we then say correlate that to, like we did in this case? Well, gosh, they got better awful quick. And what changed? Well, I pulled a bunch of stuff out of their stomach, so we stopped flowing poison basically into their blood. So that helped. That sounds like a great idea. It's hard to connect that intuitive basic science understanding to a clinical outcome. And that's the problem. And so you have a risk that you took that now has a questionable outcome and improvement. And so the risk benefit is very difficult to do. And do you put that in writing and say, this is what I want all of my crews to do? I think it's very reasonable that every intubated patient gets an 18 French Salem sump, and we attach that to suction and we pump everything out. It would leave large pills, that would leave concretions of pills, especially tablets that kind of come together. But thankfully, if we know what they took, for the most part, these agents either are not lethal or there are antidotes. If it's a ton of Tylenol tablets, they took an entire 100 count bottle of Tylenol, we do have effective antidotes for that. So would it be beneficial to place an 18 French in someone who's already unconscious and drain out what we can? Sure. I think no one would disagree with that and say that that's low risk, and everyone who gets intubated should get an OG tube and low intermittent wall suction, but not necessarily getting infusions of fluid and aspirations and so forth, unless it's those key criteria.
I like the fact that you brought up that American Academy of Clinical Toxicology guidelines are set up for the emergency room, and that is a big distinction because we're talking about pre-hospital now, and because we're talking about pre-hospital, we are able to get get to that patient sooner. It sounds like that we're talking about gastric lavage, maybe in these patients that are in severe life-threatening emergency where they are at high risk for death anyway, and you have a provider that is experienced enough to do the procedure. And that sounds great. I think that what happens in practice is that most of us in the field call poison control and just literally do whatever poison control says. So, I mean, but how do you feel about about the current state of how these cases are handled?
So again, write the protocol for all of the, with a good group for the Army and Air Force installations. And at the end of the day, reaching out to poison control is even what the emergency department does. So there's several reasons why poison control, and in New York, it's the poison center, not poison control center. Very important. The poison, when you call for poison center support, there are several things. It's tracking. That's how they get that data at the end of the year that says how many patients had Tylenol, overdoses, right?
Yeah.
And that's, that is very important. There's also the fact that there's availability of an expert. I just happen to know that baclofen was really bad for you. And, it's possible that some other physician or someone else might not have known that was, oh, that's a lethal ingestion with no real good antidote. You can give sodium bicarbonate, but most people don't take that much of it. They don't manage to, is part of the problem. It's kind of a big capsule most of the time. So you need to know that. And if you don't, you have someone you can call. So on our protocols that we wrote for Army Air Force, we want a call to poison control almost up front. And then we should probably ask, hey, is this appropriate for charcoal? We're looking at that more. One of the things about pre-hospital medicine is that things that are studied in the hospital may or may not apply. So if you look at this 1997 guidance, they came up with 60 minutes. And where did that come from? They kind of guessed. That's mostly where they a lot of things come from is that we got to have a time. I got to write this down. That's what I'm going to do, and that's what I'm going to recommend. It's same thing as blood products. At the moment, we have a hard time knowing if whole blood is better than components, especially in a pre-hospital environment. We just know that getting any blood product up front, the sooner the better. And these kind of cases that would potentially benefit from gastric lavage probably don't survive to the emergency department. That's part of it. It's kind of like why emergency physicians don't get to do a lot of cricothyrotomies. If they needed a cric, they probably died in the field, at whatever point of injury that they're dealing with. So unless they were temporized in some way, it's the same thing. So I think that poison management is overall reasonable. Our medications are safer. Most overdose and poisoning that folks are seeing that's life-threatening is opioid, and we have an effective overdose treatment. The other one that we see a lot of is acetaminophen overdoses, and that takes time usually to develop symptoms. That is amenable to charcoal, but we also have a really effective treatment that can be given in the hospital. And I guess I would just say that I don't think it's unreasonable that if you are a paramedic and your opioid overdoses very well, that you have to look at your protocol to remember certain things for some of these rare agents, or you're calling for advice, which you should do anyway. is a bad thing. I think that's very reasonable.
So before we
No,
close, do you have any final thoughts to share?
Uh, old things come back usually. It's just that they might have been overused in the past. Same thing as pre-hospital blood products, intraosseous lines. So when you got trained, same as me, I was told it could only be used in pediatrics, and
Hmm.
now you use an IO on everybody, and now we're maybe thinking that it's better in cardiac arrest. That even though epinephrine doesn't work, it's better to be given by IV. That's contradictory to me, but that's fine. The research, it is what it is. Scientific basis and an understanding of why things work is going to help us to get somewhere. And there's a balance in all things. Um, in a very, very select group of patients, it's reasonable to do gastric lavage pre-hospital. Very select. There is not that many of them. I couldn't even quantify what that number would be, and it would have to be a well-trained individual to do so.
But you found the
So
one, and I'm glad you did because we were able to talk about it today. Like many of you, I'm also an EMS instructor, so I know what it's like to have topics that are important to cover but are not actually in your curriculum. So when it comes to EMS research, I want you to know that I've been joining EMS classes lately in a virtual kind of way. It's fun for me to meet your students and talk about EMS research or even talk about how things are done differently where I am versus where you are. So if you're an EMS instructor like me and you want to give your students a flair of what EMS research is all about, just fill out the inquiry form on my website at professorbram.com. This is professorbram.com, and I'll be in touch. I want to also invite you to check out my latest book. I co-authored it with Four Arrows, who has 2 doctorates and is an expert on indigenous scholarship and hypnosis.
We've got to look at each individual patient as a human being who is in need. And we've got to know that when we're in need, we do look to others, no matter how self-reliant we are. If we are in a situation that we've never encountered before, that self-reliance begins to seek, is there anyone that can help me with this situation? I mean, you've used a pretty drastic example with the arm cut off, but I don't care how much skill you have. There's very few people who would be able to not say, "Oh my gosh, I need help," and then all of a sudden someone shows up
With a badge.
Yeah. And
Right.
you think, well, maybe this is someone that can help. Well, you said that, and I said that, during the first hour of trauma, people are essentially in a state of what we now know is hypnosis state.
I want to invite you to check it out because we introduce a method for communicating with patients on the scene of the emergency that takes advantage of some of the properties found in hypnosis. The book works to change the way we approach and interact with any emergency patient who's in acute distress, and it can help you be a better practitioner. The book is called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. Follow a link there below to find it, or you could get it almost anywhere books are sold. And if you contact me, I would be happy to mail you an autograph sticker designed to be put into the jacket cover.
Hi, I'm Will Chaplot from the International Prehospital Medicine Institute. You might know about us because of the literature reviews that we post every month free for you to review on our website at iphmi.com and also published through GEMS Online Magazine every month. We've been doing them for 5 years, so now we've accumulated over 240 literature reviews over the past 5 years. And we've gotten feedback from our audience that said they'd like to have these things as desk references, so they'd had a rapid reference. Well, we've done it. And there are now 5 volumes of these books, one for each year that we've been publishing them. This is the latest version, volume 5. And as I said, in each of these, there's at least 48 literature reviews. They're all cataloged in the beginning of the book, so you can see what the topic area is, what pages those reviews are on, and how you can find them quickly. And again, these are a great reference whether you're putting a lecture together, working on a paper, studying, whatever it is. This gives you the depth of field of the science that dictates what we do in the field or what we should be doing in the field or why we've changed the way we do things in the field. In any event, as with all of our publications, we've priced these because we want you to be able to have this book. It's only $4.99 in the hard copy here, and they're all 5 of them are available at that price. But you can also get them as ebooks, and they're available as ebooks from Amazon, from Apple, from Barnes & Noble, wherever you get your ebooks for the price of $2.99. So again, we don't do this with an aim towards getting wealthy. We do these because we want you guys to be able to have these materials, relevant information, affordable information, and an access so you can get to it. So you want the hard copies, go on Amazon, $4.99. Go to your ebook store and you get it for $2.99. If you're in the business, this is the kind of material you want to have around to settle those firehouse arguments or to help you put your materials together. Thanks again. See you all soon.
I'm doing a research project related to first responders who live in the United States, and I could use your help if you don't mind being interviewed over a video call. Go to my website and fill out the form. It's at professorbram.com, professorbram.com. I just want to thank you for listening, and I look forward to sharing more insights with you in the next episode. If you enjoy EMS research, please tell your friends and like, share, and subscribe to help others get the message.